So as I said, just welcome back to the newly diagnosed chapter, or if you're new, welcome. This is part of the Myeloma Crowd Community by HealthTree program, or Myeloma Crowd Community Program by HealthTree, excuse me. And my name is Audrey Burton Pesky, and I'm the Myeloma Community Manager. We're joined today by Dr. John Killip. He is a dentist, and he will be sharing with you later, and I will introduce him formally in just a moment. As always, we'd like to give a special thanks to our community event sponsors, Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. So today's topic is those pesky bone hardeners, and then patients beware. And first of all, let me say that I love this title. Dr. Killip came up with this title, and I was so excited, and I'm sure it caught your attention as well. He's going to go into something that is called, the acronym is MRONJ, and he can pronounce it better than I, but I believe it's osteocrosis of the jaw. And it's when the bone dies, I believe, but he's going to explain it much, much better than I. So let me introduce him. Dr. John W. Killip, DDS, Professor Emeritus at the UMKC School of Dentistry, is a dentist with over 53 years of experience. He graduated in 1968 from the University of Missouri at Kansas City. And as a myeloma patient himself, diagnosed in 2007, he understands the myeloma patient journey and is always willing to talk to myeloma patients and caregivers about proper dental care. That being said, let me turn the time over to you, and Dr. Killip, and we can get started.
Good morning, everybody, and thanks for being here. And thanks for the kind introduction. And we're going to really have to thank Jenny in just a minute. This is one of those kind of unheard of things that myeloma patients need to be aware of. And I'll share that every time I have spoken with a support group or a group of myeloma patients, and we've talked about this osteonecrosis of the jaw, with the M on the front of it, medication-related osteonecrosis of the jaw, someone in the back of the room will slowly raise their hand the further we get into the program and say, I have that, and I'm not sure I understand what it is, and thanks for sharing with us so that we can all learn about what this particular condition is. So I think we're ready to move forward. Again, as I mentioned earlier, I really want to thank Jenny and all of the people at HealthTree Foundation for giving us the opportunity to spend this time together. We're ready. Okay, what is medication-related osteonecrosis of the jaw? You've gotten me stumbling over that word myself this morning. We're going to start with a little bit of science. Osteo is the root word for bones. Necrosis is death of the cells, or it may include failure of the blood supply. So putting those two terms together to make osteonecrosis of the jaw, it's a circumstance where an opening occurs on that gum tissue that's covering the inside of our jaws. Normally, most frequently, it happens on the lower jaw and on the inside of the lower jaw, up next to your tongue. It's an area that the tissue pulls away. It just pulls away from covering the bone, and it exposes that bone. It can be very uncomfortable when you eat. It's uncomfortable when you breathe. The cold air gets on it, it becomes uncomfortable, and bone expansion may occur. Let's move on to the next one. A lot of the information that we're going to be sharing with you today comes from the American Association of Oral and Maxillofacial Surgeons white paper, which was written in 2014 on medication-related osteonecrosis of the jaw. Late last night, like at 10 o'clock last night, I did get a copy of it. More recent paper written by the International Myeloma Working Group. And I realistically have to tell you, I have not gone through that paper because it came in last night. So the most frequently recognized support information about this condition comes from the American Association of Oral and Maxillofacial Surgeons. Next step, please. We all have heard in our myeloma experience about lytic lesions. And lytic lesions has become more and more important characteristic of myeloma, and it's actually one of those circumstances that within the expanded CRAB symptoms of myeloma, if a patient has one lytic lesion, that's enough to be identified as a patient having myeloma. So we're talking about lytic lesions. Can you see my pointer? This is a skull, and you can see those hollowed out places in the skull. Or this is a arm bone, and you can see hollowed out places in the bone here. I think somebody's following me to help me with my pointer. Next slide, please. This is a jawbone, an x-ray of a jawbone. And it's an older person who has had broken down circumstances in their jaw. We can see broken down upper teeth. Here comes my pointer, and Audrey will follow me with that. We can see missing teeth on the lower. We can see dental work that's been done. But the most important thing for us to look at here is all of the little black spots throughout the jawbone that are areas that would be called lytic lesions or punched out lesions of that patient's jaw. Next slide, please. So let's talk a little bit about what happens in the bone and what we're talking about when those lytic lesions are made in the bone. All of us are familiar with when an orthodontist moves teeth. Either those of us in our generation have had our teeth straightened, or we have children and grandchildren that have had their teeth straightened. But two cells in the bone that we're going to talk about are osteoclasts and osteoblasts. Osteoclasts are the cells that soften the bone or allow the bone to break down. So when a tooth is being moved, osteoclasts break that bone down, and it allows the tooth to move slowly, slowly, slowly. When it's moving in the back, the osteoblasts are building the bone. And that's what allows, once that tooth has been moved, that the tooth will be in a firm position in bone. So now when we talk about medication-related osteonecrosis, the osteoblasts that are building the bone, if a patient is taking bone-strengthening medications, which most frequently are termed bisphosphonates, they incorporate that bisphosphonate into the bone to harden it. And a lot of us are patients who have had other bone diseases prior to having myeloma. So in our past, we have a history of being treated with bisphosphonates, and that's where things start building up and accumulating, and we're going to talk more and more about that. But in osteonecrosis, when the bone dies, we don't see that active bone remodeling. And those lytic lesions actually have those myeloma plasma cells in them. And so those plasma cells are multiplying and expanding, and the numbers are increasing, and they force their way into the surface of the bone, and that makes a little hole. And so that's what causes things we call lytic lesions, those little spots in our bone. But in osteonecrosis, as that bone is weakened, it has lytic lesions under it, it may have less blood supply. The tissue that covers it pulls away from the bone and exposes that bone. So I think we're going to be able to see some pictures of this happening if we go on to the next slide. Nope, we're going to talk more about it. There we go. We'll come to the picture next. Thank you for backing up with me. Oftentimes in cancers, they talk about how a cancer is staged. We recently have developed a staging process for osteonecrosis. In stage 1, the bone is exposed. It's not really uncomfortable. There's no infection present. And the initial treatment is to monitor that patient for 8 weeks. And if no changes occur, we continue to monitor them closely for quarterly. And the thing that we tell every osteonecrosis patient is meticulous home care is important. Stage 2, the bone is exposed, but there's pain. There also may be an exudate coming out of that area. Again, first step, meticulous home care. In this particular circumstance, we may prescribe an oral rinse. The name of it is chlorhexidine. It is a prescription item. And I will tell you straight out, it's one of the nastiest tasting things you'll ever put in your mouth. But it's a very effective cleaner of that area where the bone is exposed. So we do use that in a lot of osteonecrosis patients. Stage 3 is where the bone is exposed and it's painful. There's drainage coming out. It may be coming out into the mouth through that area, or it also may be beginning to drain down through the bone, extending all the way down through the bone to the bottom area. This is the time when surgical intervention may be used, but that's really an extreme circumstance. I think now we're ready to go to the photos. This is a gentleman with an area of exposed bone. We can see it. Yep, perfect, perfect, perfect. Thank you. And interestingly, the photos of the patients in our presentation today, some of them have been in our Kansas City support group. All of them have been seen in the UMKC School of Dentistry clinic. And a large number of them I've had the opportunity to visit with. They've principally been seen by our oral pathologist by the name of Craig Witt. And so these photos are from Craig, and he is who has helped me put things together. Now, if you look down in the very bottom left-hand corner, you'll see a notation that there was a tooth extracted in this area 4 years prior to the date the picture was taken. I think the next slide shows an x-ray of this particular tooth. You can see in the x-ray on the right-hand side that a tooth had been removed. And if we look really closely, move your down halfway here, there's a white area in the bone right next to the, yeah, no, do the white, yep, the white area right around in there. Not that little tiny dot, that's just a fragment on the film, but this white area, that's the area that's starting to come through the surface of the tissue on that patient. Next picture, please. Oh, in this area, these are easy to see. On this patient's lower right side, you can begin to see where the bone is expanding in this particular patient. The tissue's not completely gone yet, but where the two circles are, the tissue is pulling away and beginning to expose that bone. This picture also shows us some important things to think about. We're going to talk about the importance of really fine home care for all osteonecrosis patients. You can see that this patient has had broken down teeth, and if you start looking around the edges of the teeth, you can see that this guy is not taking real good care. He's not real clean, and there are places of dirt around the bottom of the teeth. Let's go to his x-ray. And again, it's very easy to see on the x-ray as the arrows show it. Those places that we could see on that lower jaw where the bone was expanding and beginning to come through the tissue. Next picture, please. Oh yeah, this is a good one. We were talking about this earlier. There has been a lot of dental work done on this patient, and we can see the brown spot in the center there. That is tissue that's breaking apart, and there is exposed bone underneath that area. It's stained probably from coffee, tea, that sort of thing. And also, if we look around the bottom front teeth, we can see a lot of pieces of food caught and that sort of stuff. Again, enforcing the importance of home care for osteonecrosis patients. Next slide, please. And again, on the x-ray, that's an easy place to see. Thank you. We'll go ahead. Okay, let's talk about some of this stuff that's going on in some of us as patients. As I mentioned earlier, there are a lot of patients who are myeloma patients who have been treated with these medications that are designed to strengthen the bone. They're called antiresorptive. That means they help strengthen the bone so the bone is not resorbed. Most frequently in the past, Zometa and Aredia were those medications that were used. Within the last 4 or 5 years, there have been a whole bunch of new medications developed. Just within the last week, I saw a TV advertisement for a product named Prolia, P-R-O-L-I-A. And even in that advertisement, they are acknowledging that it's very, very important to keep in touch with your healthcare team if you are beginning to experience pain in your jaw while you're on this medication. So, what is the prevalence of osteonecrosis? This is one of those things that I mentioned earlier. It doesn't occur very frequently. It just doesn't occur in the population very often. Generally, in non-cancer patients, the risk appears to be below 1%. It just doesn't occur frequently. But in cancer patients, that risk jumps up to between 9 and 12%. That's one of the reasons we have to start thinking about it as myeloma patients. Let's go to the next slide, please. And then in addition to being more prevalent in the cancer patient population, as we said, 9 to 12% of cancer patients, medication-related osteonecrosis of the jaw is more prevalent in myeloma patients than in other cancer patients. If we compare it to metastatic breast cancer patients or metastatic prostate cancer patients, there's a huge increase in multiple myeloma patients. And why is that? We don't have the facts as to why it is, but let's think about our disease. One of the things we talked about was lytic lesions in the bone. There's activity from our disease going on in the bone that is breaking down areas of the bone. And in my mind, this is what makes it more prevalent in multiple myeloma. Breast cancer patients and prostate cancer patients are soft tissue cancers. they're not bone-related cancers. And if we look at some of the other diseases and cancers that occur in bones, leukemia, lymphoma, those sort of things, they don't have lytic lesions, but we do. We've got them. You know, that's one of the bonuses that we have to realize that our experience gives us. Let's go to the next slide, please. Why are we concerned about these patients, concerned about us as patients who have had and who have been taking a bisphosphonate for previous circumstances over the years? Kind of in parentheses here, it talks about extremely long half-life. These bisphosphonates stay in our body for years and years and years. You know, the lead-up medication that we get before a stem cell transplant, that medication is put in our body, it goes into the bone marrow, it affects the bone marrow, and our liver washes that out within 24 hours. It's in, it does its job, and it's gone. But the bisphosphonates stay in our body for, it seems like forever. It's for years and years and years. I don't know that there is any data that I have seen that says exactly how long it lasts. I'm sure somebody has done that research, but it stays for a long time. So, and in the past, we have noted that patients with Zometa compared to patients who are on Aredia, there's a slightly larger number of Zometa patients that have osteonecrosis of the jaw. So we have to work with our healthcare providers and talk very strongly with them and very effectively with them to give them past experiences in our lives. And I was listening to some of the lead-up information, and I know that Jenny shared, you know, how effective it is for her and how important it was for her and how important it was for her to make it available to all of us to have an ability to have our medical records in one place, in this case in HealthTree, and so you can go back and you can talk to your doctor. I was on these medications in the past. During my myeloma treatment, I was on these medications. And I know when I started my myeloma treatment, I was on Aredia on a monthly basis for about 2 years. Let's go to the next slide, please. Why do myeloma patients have this circumstance? MRONJ occurs spontaneously. We can't identify any reason that you would get it, or that I would get it, or the person sitting next to us would not get it. But let's look at the age group of myeloma patients. It occurs most frequently in the age group over 65. A large number of us as myeloma patients are over 65. We mentioned earlier that some of those patients had missing teeth, or they had advanced periodontal bone loss. This is where the bone supporting your teeth, because of the inappropriate care, inappropriate home care, begins to move down on the surface of our teeth. It's called bone loss. Again, that's an activity that's going on in the bone. In my mind, these are the things that contribute to why it occurs in us. We saw a picture where there were dental extractions. So recent intervention or invasive procedure, a dental extraction, often is an area where the osteonecrosis will occur. If a patient is wearing a denture that's not fitting well, that may irritate the bone. So that's an area that it might occur. Smoking and diabetes can be contributing factors. But one of the things that patients always ask me is, does the high-dose chemotherapy that we receive for an autologous stem cell transplant, are either of those, the chemotherapy or the autologous stem cell transplant themselves, a significant risk factor? And the answer to that is no. There is not an increased prevalence of this circumstance in those patients. The primary things that may cause it to occur are the ones that we just discussed: age, periodontal bone loss, missing teeth, dental intervention, and possibly smoking and diabetes. Let's move forward, please. There's no test to determine who is going to get it. I mentioned earlier, there's no way to tell if I'm going to get it, or if you're going to get it, or if the person sitting next to us is going to get it. There's no test that will eliminate that. Are there things that we can do to lower the risk? Yes, and we continue to emphasize good oral hygiene and regular dental care probably do help lower the risk of one of us getting it. Next slide, please. So it's very, very, very important for us to communicate, and we had talked a little bit about this earlier. It's very important for us to communicate to our myeloma doctors, to the doctors who are treating us for myeloma, as well as our general intern doctors, and as well as our dentists. We've got to put all of these pieces together. And that's one of Jenny's important points. You have all of these things coming from different directions, different doctors, different ideas, and it's important to put that together. It's important to share that. I remember one of the very first times I talked to a support group in St. Louis, I mentioned how important it was to communicate to our dentists that we are myeloma patients and what medications we're on, what medications we've had in the past. And a lady raised her hand and she said, I just can't tell my dentist that. And I said, why not? And she said, well, he grew up next to me. He used to cut my lawn. He used to shovel my snow. He's just the finest young man. I was so excited when he went off to dental school and he came back, and I chose him to be my dental care provider. And I can't talk about those personal things. Well, we're not talking about personal things. We're talking about sharing our medical history. And she said, I just can't do that. So I'm smart aleck enough, and I have worked in dental education in Missouri at the University of Missouri, Kansas City School of Dentistry for over 20 years. And we were the primary provider for dentists in Missouri. So my smart mouth probably got me into trouble. I said, if you don't tell him, I'm going to call him up and I'm going to tell him. And she kind of cowered in the corner, and I kind of felt maybe a little guilty for having said that. But I saw the lady about 2 years later, and she said, thank you for telling me to do that. Because I did communicate with my dentist that I am a multiple myeloma patient and the medications that I'm on. And he was so supportive, and he said it's so important for all of our healthcare providers to know all of what's going on in our health systems at this point in time. So I guess I didn't get myself in trouble, or maybe I got myself out of trouble, but it really is important to communicate with all of our care providers. Questions come up if I'm anticipating that I'm going to have some dental care done. What should I do? Routine dental care, cleaning, polishing, a general filling, even a root canal, they're okay to do without too much concern, because those are all inside of the teeth or on the surface of the teeth. They're not getting down into the bone where some of the trouble may begin. So keep up with your dental care. People sometimes ask, should I take a bisphosphonate vacation prior to dental care? Probably not, because as we mentioned earlier, these bisphosphonates have such a long half-life in our bodies that if you dropped off of bisphosphonate care for 6 weeks or a month, still that's not going to eliminate them from your system. So a drug holiday is not really a necessary idea. And in those patients with low bone mass, that may cause a problem because their bone mass decreases. We've found that people who are taking oral medications rather than those medications who are infused are having less of this circumstance. So at this point in time, all providers have agreed that there should be a 2-year limitation on giving patients bisphosphonates or bone hardening medications. And I know a lot of people at this point in time, when I was on Aredia, I was having monthly infusions. Now people are doing every 6 months. The medications are made to where they only have to be given to the patient every 6 months. So even the manufacturers are making changes because they realize the importance of limiting the amount of exposure that patients have. Let's move forward, please. I had mentioned earlier that most of these lesions occur on the inside of the lower jaw. Very infrequently do they occur on the upper jaw, on the palate, the roof of the mouth. But one of the conversations that I've had recently was with a patient who was experiencing it on the upper jaw. She's a female patient. Obviously, this is a male patient. So she's one of those unique people that she's possibly experiencing osteonecrosis on the upper jaw. Next, please. So just a few more points. Multiple myeloma patients are not candidates for new dental implants. If you had an implant done 5 years ago, keep it clean, just keep on top of it. Make sure your dentist is looking at what's happening in the bone adjacent to the tooth. If there are any changes in that bone, I said adjacent to the tooth, I mean, make sure that he's looking at the dental implants. If there are any changes in the bone, that's something to be very, 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 very well aware of. Again, we talked about every care provider needs to be informed of what medications a patient is on, and the patients need to be informed of all of the risks provided by that medication. That's all of our medications. It's important for us to know. Complete dental examinations as we become a myeloma patient are very, very important. I remember when I was initially diagnosed, one of the first things my doctor said is get a complete dental examination. Make sure that everything is under control. Any active cavity or periodontal infection should be treated readily. And as I mentioned earlier, work within the teeth, fillings, restorations, root canals. Those are all important things, and they can be very easily done and with no concern about possible future osteonecrosis. Any potential sites of new infection should be removed. That's important for all of us as patients, to make sure that everything is stable and under control. Any unsalvageable teeth should be extracted pretty early in the process. Next slide, please. There's really no treatment. You know, I'm sitting here kind of bouncing around. People have asked, should the skin, the mucosa, be closed? think about it if you have an open lesion on your hand or anywhere. That skin around that lesion is tender. It's not as strong as it was. In the mouth, if we were to try to put a suture through that skin and pull it over that bone, we're stretching that mucosa or that skin, and the tissue is not strong. Sutures don't hold, so that's not a way to treat it. We mentioned getting things done early. Excellent hygiene is the very, very, very best thing. We mentioned that there is an oral mouth rinse that we can use. Some people, and that's where we talk about topical or oral antimicrobials. There are some people who have questioned whether vitamin E is an appropriate treatment modality, but there's nothing to back that up. Let's go to the next slide, please. And people have talked about whether laser therapy is advantageous. And the most recent research shows that there is a certain wavelength of laser that may be helpful in resurfacing that bone, smoothing that bone, and encouraging the gum tissue to grow back over. Antibiotics are very important if there is infection involved. And I have mentioned before that chlorhexidine rinses. I read one or two articles that say that use of hyperbaric oxygen therapy in a hyperbaric oxygen chamber may be effective, but the research is so early that it's hard to even suggest that. And we continue to go back to the importance of meticulous and regular oral hygiene and dental care. Let's go next. So we're kind of to the end of my things that I wanted to share. I'm very, very open to questions. I was speaking earlier. One of my silly statements is I like to turn those question marks into exclamation points. And so I think there are some questions in the chat, and we'll hopefully be able to answer those questions for you.
Yes. So there's several questions and I'm excited to ask them. We'll start with this one. They say that they were diagnosed with Zometa-induced osteonecrosis of the jaw. The bone miraculously loosened. The oral surgeon simply removed the bone and said that their gum was healing. He or she attributes this to prayer. It's anonymous, so I'm not sure. The Zometa was discontinued. In your opinion, do you think the bone growth will likely return?
That has lots of directions.
Multi-layered.
Most frequently, when things are clean, when the bone, I heard a statement about that the oral surgeon removed a piece of bone.
Mm-hmm.
That could be a fragment of bone that was left over from an extraction site or something like that. So that would be easy. But if it's osteonecrosis going on, if the bone, occasionally they will smooth it down, but you kind of have to think about the surface of the bone is very, very smooth, although it's porous. And you take a piece of sandpaper or a disc or some sort of a file that an oral surgeon might have, and he says he's going to smooth it down. Realistically, it's never going to be as smooth as it was made. And so we have to be aware of what the blood supply is coming to that area. And the hope is that if the blood supply gets better and the bone is smooth, that the tissue will grow back over. And most people in stage 1 or the early stages of osteonecrosis, it will close down, but it takes a lot of time and it takes a lot of good oral hygiene. We just keep going back to good oral hygiene.
That's great. Thank you. All right. Next question. What are the long-term effects of few or several years of Zometa and Aredia? Is that how you say it? After the treatment was stopped. I've read that with Zometa, the osteoblasts create new bone over old bone, and the old bone has a more crystalline and weaker structure than a healthy bone, wherein the osteoclasts are able to get rid of before new bone is laid down. So I think just, if you can tell us the long-term effects of having those kind of, what was it, biophosphonate medication?
Bisphosphonate. Uh, you and I were talking earlier, and we actually took a slide out of the show that had a picture that had a layer of bone, and then on top of that layer of bone, it showed a hardened layer of bone, which the drawing was indicating that was bone that was harder because it had been treated with one of the bisphosphonates, so it was harder. And it actually had a little osteoclast up here above it that was kind of trying to break that down. The bone is hardened by the bisphosphonates. I don't know that I can answer that fully beyond, that's why I took the slide out, because I was not comfortable with what I was saying on the slide. So I apologize. I can't answer that too much more effectively.
No, it's okay. Thank you. do you want me to show the slide or do you want to just?
I'm uncomfortable with what I saw on that.
No, that's fine. That's fine. So, I think that emphasizes the point though of talking to your own medical treating team about what, you're on and what the consequences are of those medications and things like that. Okay, Doug says my salivary glands did not recover well after my transplant and I have a dry mouth. Does this have any impact on potential MRONJ?
Initially, no. I want to say no. But I do know that people with dry mouth suffer from a little bit more gum disease than the rest of us because their gum tissues are not lubricated. I know that they have uncomfortable circumstances when they're speaking because their lips and their tongue don't flow around quite as much. But I have not seen any indication that says dry mouth is going to lead to osteonecrosis.
Does having torus in my lower jaw cause me to have a higher risk for ONJ?
No, and thank you for bringing that forward because those tori, a lot of us can feel the inside of our lower jaw, and there are bumps of bone. Some of them are big, some of them are just, I can feel little tiny ones that are smaller than a pea, but not as big as they're tiny on me. My mother had huge tori, the official name is mandibular tori. My mother had huge ones, and I'm glad I don't. But no, tori is not a precursor to osteonecrosis.
Great. What about the safety of gum grafting for receding gums?
That's going to a different direction that's away from the osteonecrosis circumstances, but periodontal surgeons and periodontists often do use gum grafting to increase the height of gums where they have receded. And so in the appropriate places, yeah, do them. But that's not totally related to today.
Okay. Well, so we're talking about, taking care of your mouth. Will having regular cleanings and checkups every 6 months be sufficient, or should they be looking for more frequent dentist visits?
That one, I think, generally we think that the 6-month checkup time is appropriate. I'm a person who builds up tartar and collects a lot of that buildup on the back of my teeth. So I actually have my checkups every 4 months. Okay. But again, keeping on top of it daily with your daily oral hygiene processes and and regular checkups, that's very appropriate.
Awesome. All right. Yvonne has a great question. She was treated in 2018 with Zometa, and we talked about that these have, stay in your body for quite some time, but now it's going on 3 years. So can she get a tooth extraction now?
If the tooth needs to be taken out, it needs to be taken out. And one of my oral surgeon friends, and I've said to him, one of my fears as a myeloma patient is that I'm going to come up to a circumstance where I have to have a tooth taken out. And he always says, well, number one, I'm not going to get to that circumstance because I do my best to take care of things.
Yeah.
But he always says and assures me that a skillful oral surgeon can do those extractions for you without much fear.
Right.
So he reinforces the skill of the oral surgeon, but also take care of yourself.
I like that. All right, we have a patient who's very newly diagnosed, meeting with their oncologist next Monday to discuss the treatment plan. At our last appointment, he said that I should get all my dental work done ASAP, but I have a root canal scheduled for the 22nd of April. After that, they will put a crown on it. Should I tell my oncologist to hold the bisphosphonates until the crown is on?
Your timing is perfect, actually. You said you're having your root canal done next week or in the next few days. Mm-hmm. And those things that are internal to the tooth are generally very, very safe. They don't involve things that change the bone structure. And putting the crown on is going to be a good thing. It'll make that tooth stronger and it'll go further. But just mention to him, your oncologist, when you meet with him and say, responding to your suggestion that I get all of this taken care of as quickly as I can, this is what the sequence is, and I think you're going to be in wonderful shape.
Mm-hmm. All right, there's a lot of questions, so I'm sorry. I'm going to try to hit as many as we can. How do you, so again, we hear about great oral hygiene. What does that mean? Does that mean brushing 2 or 3 times a day for 2 minutes plus an oral rinse, flossing? Give your best dentist advice. When you say take care of your teeth, what does that mean?
Well, we all watch those advertisements on TV where the dental hygienist tells you this and the play dentist tells you that. There is evidence that an electric toothbrush cleans better than a hand toothbrushing. There is, in certain people who have open spaces between their teeth, Proxyjet that blasts that water in between there helps to clean. Good oral hygiene really is keeping all of the loose leftover food particles away, getting all of the plaque that's building up, getting that off on a regular basis, and that's a soft material. So brushing, flossing is very helpful between the teeth. As we get older and those spaces between our teeth are a little bit more open, there's a product, a Proxa brush, and those are very handy for those of us that are getting the dental term long in tooth. And it's just, you don't have to specifically say brush 8, 10, and 2, and 12, but a normal routine on a daily basis, cleaning your teeth regularly. I personally brush twice a day. I use a Proxa brush. And so it's just keeping yourself clean.
Yeah, awesome. Okay. So we've gotten a couple questions about the bone medication called, I don't know how to pronounce it, but it's XGEVA. So Xgeva maybe? Does it have the same risks as the Zometa and Aredia? I know that's a question that they're asking about this bone medication, if you know anything about it.
Okay, I know a little bit about it, but not a lot. The most recent medications that are being developed by pharmaceutical companies are not all specifically bisphosphonate based, but they have a similar action of hardening the bones. And that's one of the reasons that looking at this process, and I mentioned that the name has evolved over the years. At one point in time, it was MRONJ, BRONJ, which was specifically related to bisphosphonates. And then it's evolved to MRONJ, which is medicated related osteonecrosis of the jaw. All of those medications, we just have to be very, very careful that we're not overloading a patient with them. And patients that are coming to us as myeloma patients that have a history of osteoporosis in the past where they've taken bone strengthening medications have that in their systems, and they have them in the past. So we have to be very careful to not overload the patient.
Thank you. Okay. There's just so many, sometimes it's hard to decide. So I guess one of the questions that's coming up frequently is, are you know what I'm talking
Bisphosphonate.
about? I can see it in my head and I can hear you say it and the mouth still doesn't function. Are those taken forever, or are those taken only for a set period of time? Or what's your experience with that?
Right now, we're all in agreement that those should be limited as 2 years.
Okay.
So it's not something that goes on forever. In the past, it used to go on longer and longer and longer, but all the medical doctors and the dentists are all in agreement that 2 years is the ideal length of time. And then one of the things that I have thought about and that I mentioned earlier is that some people who have the need for their osteoporosis and other bone conditions, they're now spacing out treatments every 6 months rather than doing it monthly. So that's kind of the way the medical side of the process is handling it at this point in time. But a consistent monthly treatment for 2 years, cut it off.
And what are the risks of cutting it off? Are you more prone to bone lesions then? Or because it stays in your body for so long?
It stays in your body for a long time, so you have that protection. But it's really the protection for the strength of the bone and the bone hardness, bone density loss. That's what we're giving it for. We're not really giving it because I'm going to stop there.
No, it's good. It's okay. So I think if I just understood, we just have a couple questions about, is there an alternative? If I'm taking Zometa monthly, is it better to take it every 3 months?
It's a determination that your physician and your care providers would have to make.
Yeah.
I'm not able to sit out here in Kansas City and tell you what's going on in New York.
But it is a good, now perhaps you're a little bit more educated as a patient and can go more empowered to your dentist to talk to him about that. Let's see. There are papers suggesting that chlorhexidine can affect bone growth and maybe not a good idea. Do you have any comment on that?
No, I don't, because I haven't seen those papers.
Okay, good to know. Do you know, are you familiar with the drug romosozumab?
No.
Okay. What about I'm sorry, guys, pimodronate. Pimodronate?
I can't respond to specific medication.
Okay, I think that's a safe answer. I had not me, but this patient had a tooth extracted 4 months ago. Oral surgeon said it was okay for implant as well as a myeloma doc. So they were diagnosed 9 years ago, had Zometa for 2 years and none in the last 7 years, and have not had any bone involvement as a side effect of their myeloma. Is it still recommended in this case, generally, not speaking specifically to this patient, but let's say generally, is it a no implant at all for myeloma patients?
The statement that I made about that myeloma patients are not candidates for dental implants comes directly from that white paper from the American Association of Oral and Maxillofacial Surgeons. And conversations that I've had with the oral surgeon friends that I have, they're not in favor of implants in myeloma patients.
Okay. And I will be sending.
I will just put a little story in there. There's a lady in our support group that I've known for many, many years, and she will come up to me at meetings every once in a while and she will say, I had an implant. And so it really is a decision that you and your care providers can make. My statement comes from the recommendation from that particular paper.
And that paper will be shared with all of you in the follow-up email that we will be sending after this event is over, along with recording and the slides that will be shared with you today. Let's get a couple more questions, and then we can be done for today. So, is loss of enamel a risk factor for ONJ?
No.
Okay. Do you recommend using a water pick? I think we talked about that a little bit. But
water picks are good if to help blast that food that's caught between your teeth, and they're good. Use them in addition to your toothbrushing. And I've noticed an advertisement recently for a electric toothbrush with a spin head that has a water pick in the center of it. So
wow.
Double duty on that guy.
Intense toothbrush. Doreen is asking if you can clarify your statement that oral medication is less damaging.
That just, I can't cite the reference, but I have read that in a couple of papers.
Okay. I think that's where we're gonna leave off. I think we answered the general consensus of questions. I'm so sorry if we didn't reach your specific question at this time, but thank you, Dr. Killip, for joining us today. I'm just going to close out with a couple slides. One moment. Oh. Well, let me pull up the slides again because somehow my computer decided to.
While you're doing that, it's been a treat for me to do this, and I appreciate the opportunity and wish everybody well on their myeloma journeys.
Thank you. He just got back from vacation, you guys, and decided to share with you today. So we're really grateful for him and his desire to share with us. All right, so our next meeting of the newly diagnosed myeloma patients chapter will occur on May 20th at 1 p.m. Eastern, and we're going to have a myeloma coach panel of experienced myeloma patients talk about questions to ask your doctor at diagnosis. And by at diagnosis, even in that first year, myeloma is so new, most of us haven't even heard of myeloma before being diagnosed. And there's so many questions, there's overwhelming information sometimes that's given, and there's lots of inaccurate information that's given over the internet. So what are the questions that we really should be asking our doctor during that first year as we get that induction therapy? So make sure to join us for that coach panel and to come with questions because it's going to be interactive. You might be interested in upcoming events that we have in the Myeloma Crowd Community Program. Tonight at 7 p.m. Eastern, we're actually going to have our Myeloma Caregivers chapter. Myeloma financial coach Diana Valentine will be sharing financial resources for the caregivers. And as a former myeloma caregiver herself, she will be sharing bits of her story and her experience as well. Wednesday, April 21st at 3 p.m. is the Connect 3 p.m. Eastern is the Connect with Myeloma Crowd chapter. We're going to be talking about finding support through the Myeloma Coach program. And our Myeloma Coach program director, Rosalind Height, will be leading that conversation. Thursday, April 22nd at 12 p.m. Eastern is our African American Myeloma chapter. We're going to be talking about real data of African Americans with myeloma. And it's amazing research that has recently come out, findings that has come out thanks to HealthTree Cure Hub and the research team. We're excited to share that. And then on Tuesday, April 27th at 12 p.m. Eastern, is their Nutrition and Wellness for Myeloma chapter. Dr. Gulati is going to be sharing how to regulate your diabetes through nutrition. And on Wednesday, April 28th at 1 p.m. Eastern, that's wrong. I must have typed that wrong last night. I am so sorry. And Wednesday, April 28th at 1 p.m. Eastern is our selinexor. I will make sure to correct that before sending these out to you. But it's going to be our selinexor support group. And Beth Ian, who is a patient that was diagnosed really young and has had myeloma for quite some time, is going to be sharing her story. When she was refractory to so many different medications, she was able to find hope through selinexor or XPOVIO. The link to sign up for any of these events is found here, www.myelomacrowd.org/events. Again, a special thanks to our community event sponsors, without whom this would not be possible. Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, AbbVie, Adaptive Biotechnologies, Genentech, Oncopeptides, and Takeda Oncology. And thank you so much for joining our myeloma community, our newly diagnosed chapter. I'm so excited to have you. And thank you, Dr. Killip, for your time. We really appreciate you. Have a great time.